Today's seminar is about anxiety disorders. Introduction. Anxiety is a diffuse, highly unpleasant, often vague feeling of apprehension accompanied by one or more bodily sensations, palpitations, respirations, headache, etc. Anxiety can produce uncomfortable and potentially irritating psychological like worry or fear of feeling of threat and physiological arousal like tachycardia or shortness of breath. Definition. It's a feeling of apprehension caused by anticipation of danger, which may be internal or external. Anxiety is an emotional state commonly caused by the perception of real or perceived danger that threatens the security of an individual. It allows a person to prepare for or react to environmental changes. Epidemiology. According to large population-based surveys, up to 33.7% of the population are affected by an anxiety disorder during their lifetime. As in adults, anxiety disorders are most common class of mental disorders with a 12-month prevalence rate of 24.9%. Female to male ratio of prevalence rates of anxiety disorders as per National Comorbidity Survey replication were as follows. Panic disorders being the most common of all them and female being the most affected. Gender and socio-cultural factors. Women are twice as likely as men to have anxiety disorder. Possible explanations would be women may be more likely to report symptoms, men more likely to be encouraged to face fears, women more likely to experience childhood sexual abuse, women show more biological stress reactivity. And cultural factors would be culture can shape anxieties and fears. Rate of anxiety disorders varies by culture, but ratio of somatic to psychological symptoms appears similar. Changes from DSM-4 to 5. DSM-5 includes selective mutism and separation anxiety disorder into anxiety disorders and changing the name of social phobia to social anxiety disorder. 5 removes panic attack as a specifier for agoraphobia and assigning panic attack as a specifier that may be applied to wide array of DSM-5 diagnoses. Removing OCD, PTSD and ASD from this category of anxiety disorders in DSM-5. DSM-5 anxiety disorders. Most common of them are specific phobias, special anxiety, social anxiety disorder, panic disorder, agoraphobia, generalized anxiety disorder. Others would be separation anxiety disorder, selective mutism, substance of criteria for anxiety disorders. DSM-5 criteria for each disorder. In general, symptoms interfere with important areas of functioning or cause marked distress. Symptoms are not caused by a drug or a medical condition, and symptoms persist for at least 6 months or at least 1 month for panic disorder. And the fears and anxieties are distinct from the symptoms of other anxiety disorders. Phobias. It's a destructive fear of a particular object or situation. Fear is out of proportion to actual threat, and awareness that fear is excessive must be severe enough to cause distress or interfere with job or social life by avoidance pattern. Specific phobias. Disproportionate fear of a particular object or situation. The common examples would be fear of flying, fear of snakes, fear of heights, etc. Fear out of proportion to the actual threat is seen in this. And awareness that fear is excessive. And most specific phobias cluster around a few feared objects and situations. It's a high comorbidity of specific phobias. DSM criteria for specific phobia is marked and disproportionate fear consistently triggered by specific objects or situations, and the object or situation is avoided or else endued with intense anxiety, and the symptoms persist for at least 6 months. Types of specific phobias would be fear of animals like snakes and insects, and natural environment like storms, heights, and water. And being the associated characters being generally begins during the childhood, and fear of blood injection or any medical procedures clearly runs in the families, and the profile of heart rate where the profile of heart rate slowing and possible fainting when facing fear stillness is being observed. And situational fears like public transportation, tunnels, bridges, elevators, flight, driving, and closed spaces. These tend to begin either in childhood or in mid-20s, and others being choking, contracting and illness, etc. Children's fears of loud sounds, clowns, etc. is being common. Social anxiety disorder, previously called social phobia, causes more life disruption than other phobias, more intense and extensive than shyness. is a persistent, intense fear and avoidance of social situations, fear of negative evaluation of scrutiny in those situations. Exposure to trigger leads to anxiety about being humiliated or embarrassed socially. Onset is often in the adolescence. 33% also diagnosed with avoidant personality disorder, who is also having social anxiety disorder, and overlapping genetic vulnerability for both disorders is being seen. DSM-5 criteria for social anxiety disorder. It's a marked and disproportionate fear consistently triggered by exposure to potential social scrutiny. Exposure to the trigger leads to intense anxiety about being evaluated negatively. Trigger situations are avoided or else endure with intense anxiety, and symptom persists for at least 6 months. Panic disorder. Frequent panic attacks unrelated to a specific situation. Panic attack is defined as a sudden, intense episode of apprehension, terror, feelings of impending doom, with an intense urge to flee. Symptoms reach peak within the intensity exposure of 10 minutes. Physical symptoms can include labored breathing, heart palpitations, nausea, stomach upset, chest pain, feelings of choking and smothering, dizziness, sweating, lightheadedness, chills, heat sensations, and trembling. And other symptoms may include depersonalization, derealization, fear of going crazy, losing control, or dying. 25% of the people will experience a single panic attack in their lifetime, and not the same as panic disorder, as panic disorder need to be included multiple panic attacks. Uncured panic attacks occur unexpectedly without warning, and panic disorder diagnosis requires recurrent uncured attacks. Causes worry about future attacks. Acute panic attacks are triggered by specific situations like seeing a snake of fear of heights, etc., and more likely a specific phobia. Jason 5 criteria for panic disorder. Recurrent unexpected panic attacks within at least lasting for 1 month of concern about the possibility of more and the concern of possibility of more attacks and worry about the consequences of an attack or maladaptive behavioral changes because of those attacks. Agoraphobia. It is derived from the Greek word agora or marketplace, anxiety about inability to flee anxiety provoking situations. Example crowds, stores, malls, churches, trains, bridges, tunnels, etc. Causes significant impairment as the individuals avoid those situations. In DSM-4, it was a subtype of panic disorder, and at least half of agoraphobias do not suffer panic attacks. DSM-5 criteria for agoraphobia. Disproportionate and marked fear or anxiety about at least two situations where it would be difficult to escape or receive help in the event of incapacitation or panic-like symptoms such as being outside of the home alone, traveling on public transportation, open spaces such as parking lots and marketplaces, being in shops, theaters, or cinemas, standing in line or being in a crowd. These situations consistently provoke fear or anxiety. These situations are avoided require the presence of companion or an individual with intense fear or anxiety, and symptoms last at least for 6 months. Generalized anxiety disorder. It involves chronic, excessive, generalized, uncontrollable worry, which lasts for at least 6 months, interferes with daily life, and often cannot decide on a solution or a course of action. Other symptoms would be restlessness, poor concentration, tiring easily, irritability, muscle tension. Common worries would be relationships, health, finance, and daily hassles. Often begins in adolescence or earlier. Individual would be always saying, I have been always in this way since childhood. DSM-5 criteria for generalized anxiety disorder. These are excessive anxiety and worry at least 50% of the days about at least two life domains. The domains would be family, health, finances, work, and school. The person finds it hard to control the worry, and the worry is sustained for at least 3 months. The anxiety and worry are associated with at least three of the following: restlessness or feeling keyed up or on edge, being easily fatigued, irritability, muscle tension, sleep disturbances. And the anxiety and worry are associated with marked avoidance of situations, marked time and effort for the preparation of for the situations, marked procrastination, difficulty building relations into worries, and repeatedly seeking reassurance from others. Anxiety to three weeks. Anxiety is an increasingly common psychological disorder throughout our society with many different types. One of the psychoanalytic, trait theory, biological, humanistic, behavioral and social learning theory, and cognitive theory. Psychoanalytic theory, given by Sigmund Freud, uh, cause of most disorders stem from our unconsciousness. In this, the relationship between consciousness and unconscious mental process. Freud then determined and formed a therapy using his beliefs, which were highly opposed for psychoanalysis. Psychoanalysis is generally a time-consuming process, often taking years to treat the patient. The biological theory is based on the concept that your personality is influenced by genetics. Given by Hans Eysenck, treatment meant to alter the brain functions to repair behavior that is causing suffering in the patient. Generally include drugs to try and balance out the brain chemistry. Behavioral and social learning is focused on seeking out and achieving pleasurable goals, and a combination of genetics and learning different behaviors is included. Generally, cognitive and behavioral therapy is used. Usually focuses on identifying, understanding, and changing thinking and behavior patterns. Benefits are usually seen within 12 to 16 weeks. Cognitive theory says understand human behavior by examining the thought process. Controlled clinical trials show that cognitive behavioral therapy is effective for generalized anxiety disorder, and with this approach, medication is also an option to be combined with therapy. Trait theory says that the approach is looking at the correlation. If you can identify the trait, and are you able to predict behavior for an individual? Trait theorists spend less time examining why people behave a certain way. They focus more on their personality and predicting someone's behavior. An humanistic approach would focus on personal responsibility and personal growth, and it is more of a positive outlook on life. Also focus on being a fully functioning adult and being able to process and accept information no matter how pleasant it is. Comorbidities include 50% of those with anxiety disorder meet criteria for another anxiety disorder, and 75% of those with anxiety disorder meet criteria for another psychological disorder. Disorder commonly comorbid with anxiety are depression, substance abuse, personality disorders, and medical disorders like coronary heart disease. Neurobiology. The core symptoms of anxiety are fear and worry. Fear consisting panic and phobia, and worry consisting anxious misery, apprehensive expectation, and obsessions. Fear symptoms are regulated by amygdala central circuit, and the worry are regulated by postgraduate circuit. These circuits may be involved in all anxiety disorders with different phenotypes not reflecting any unique circuit, but rather divergent malfunction within those circuits. Fear expression. Feelings of fear are regulated by reciprocal connection between the amygdala and the anterior cingulate cortex and the amygdala and the orbital frontal cortex. Specifically, it may be that overactivation of these circuits produces feelings of fear. Avoidance, fight, flight, freeze, motor response. Feelings of fear may be expressed through behaviors such as avoidance, which is partly regulated by reciprocal connections between amygdala and the periaqueductal brain. Avoidance in this sense is a motor response, and other motor responses are to be fight or to run away in order to survive threats from the environment. Worry and obsessions. These are shown here in a corticostriatal group originating and ending in the dorsolateral prefrontal cortex. Overactivation of this circuit may lead to worry or obsession. Hyperventilation. Changes in the respiratory rate occur during a fear response, and these changes are regulated by activation of the parabrachial nucleus via the amygdala. Inappropriate or excessive activation of the parabrachial nucleus can lead not only to increase in the rate of respiration but also various symptoms like shortness of breath, exacerbation of asthma if an individual already has, and a sense of being smaller. Autonomic output of fear. Autonomic responses are typically associated with feelings of fear. These include increase of heart rate, blood pressure, which are regulated by reciprocal connection between amygdala and the locus coeruleus. Long-term activation of this circuit may lead to increased risk of atherosclerosis, cardiac ischemia, increased blood pressure, increased heart rate, and myocardial infarction, and also may lead to sudden death. Endocrine output of health. Endocrine effects such as increasing cortisol, which occur because of irregular activation of the hypothalamo-pituitary adrenal axis. Prolonged HPA activation and cortisol release can have significant health implications such as increased risk of coronary heart disease, type 2 diabetes, and stroke. Hippocampus and experience. Anxiety can be triggered not only by the external stimulus but also by an individual's memory. Traumatic memory stored in the hippocampus can activate the amygdala, causing the amygdala in turn to activate other brain regions and generate a fear response. It is termed as experiencing and see conditions like post-traumatic stress disorder. Stress and the HPA axis. The central role of HPA axis is stress proxy. The normal stress response involves activation of hypothalamus and a resultant increase in the corticotropin releasing factor, which in turn stimulates the release of ACTH from the pituitary gland. ACTH causes glucocorticoid release from the adrenal gland, which binds to the receptors of hypothalamus, pituitary, and hippocampus. Glucocorticoid binding in the hypothalamus inhibits CRF release, ending the stress response. In addition, the hippocampus plays a role in inhibiting the stress response, and in situations like chronic stress, excessive glucocorticoid release may eventually lead to hippocampal atrophy, thus preventing it from inhibiting the HPA axis, and this could contribute to the chronic activation of HPA axis, which leads to increased risk of anxiety disorder. Pathophysiology. Data from biochemical and neuroimaging studies indicate that modulation of normal and pathological anxiety states is associated with multiple regions of the brain and abnormal function in several neurotransmitter systems, including norepinephrine, serotonin, and gamma aminobutyric acid. Neurotransmitter factors. In the neurotransmitters, neurotransmitters involved in amygdala central circuit are 5-HT, GABA, glutamate, corticotropin releasing factor from the HPA axis, norepinephrine, voltage gated ion channels. And from the worry loop are 5-HT, GABA, glutamate, dopamine, norepinephrine, voltage gated ion channels. Noradrenergic model. This model suggests that the autonomic nervous system of anxious patients is hypersensitivity and overreacts to various stimuli. The locus ceruleus may have a role in regulating anxiety as it activates norepinephrine release and stimulates the sympathetic and parasympathetic nervous system. 5-HT model. Generalized anxiety disorder symptoms may reflect excessive 5-HT transmission or overactivity of the stimulating 5-HT pathways, and the role of 5-HT in panic disorder is unclear, but it may have a role in development of anticipatory anxiety. Preliminary data suggests that 5-HT and 5-HT2 antagonist methamphenyl piperazine causes increased anxiety in post-traumatic stress disorder patients. Gamma aminobutyric acid receptor model. It's a major inhibitory neurotransmitter in the CNS, and many anti-anxiety drugs target this GABA receptor. Benzodiazepines enhance the inhibitory effects of GABA, which has a strong regulatory or inhibitory effect on serotonin, norepinephrine, and dopamine systems. Anxiety symptoms may be linked to underactivity of GABA systems or downregulated central benzodiazepine receptors. In patients with generalized anxiety disorder, benzodiazepine binding in the left temporal lobe is reduced. Abnormal sensitivity to antagonism of the benzodiazepine binding site and decreased binding was demonstrated in panic disorder. Abnormalities of GABA inhibition may lead to increased response to stress in post-traumatic disorder patients. And investigations to be done are blood glucose to rule out type 2 diabetes mellitus, lipid profile, cortisol levels, and urine drug screen, which is to be ruled out suspected stimulant abuse, and thyroid function test to rule out any thyroid disorders, 24-hour urine test for vanillin, mandelic acid, and metanephrine to rule out tachycardia and hypertension, which are due to fear thrombocytoma, and ECG and echocardiogram for high-risk patients of cardiac disease or evidence of any cardiac disease, and pulmonary function test for evidence of any pulmonary disease with patients of shortness of breath, and EEG for evaluating patients where anxiety is suspected to be seizure prodromal. Scales used for anxiety disorders are brief fear of negative evaluation scale, depression anxiety stress scale, generalized anxiety disorder questionnaire 4, and generalized anxiety disorder 7, Hamilton anxiety rating scale, overall anxiety severity and impairment scale, fear questionnaire, 10 state worry questionnaire, and social phobia inventory. Treatment would be pharmacological and non-pharmacological, which is psychotherapy. Pharmacological, three major neurotransmitters are targeted in pharmacological treatment of anxiety disorders. Sir, GABA by benzodiazepines, serotonin receptor by SSRIs, and norepinephrine receptors by SNRIs. Benzodiazepines. They are perhaps the best known and most widely used anxiolytics, act by enhancing GABA actions at the level of amygdala and at the level of prefrontal cortex with cortical striatothalamic thalamic thalamic circuits groups to relieve anxiety. Three major types are 1,4 benzodiazepines, 1,5 benzodiazepines, and 2,3 benzodiazepines. And serotonin reuptake inhibitors. It's a key neurotransmitter that innervates the amygdala as well as the elements of CSTC circuits, namely prefrontal cortex, striatum, and thalamus, and thus is poised to regulate both fear and worry. Antidepressants that can increase serotonin output by blocking the serotonin receptor are also effective in reducing symptoms of anxiety and fear in everyone of the anxiety disorder. Non-epinephrine reuptake inhibitor. Symptoms of hyperarousal such as nightmares can be reduced and worry can be reduced by norepinephrine reuptake inhibitors, also called norepinephrine transporter inhibitors. Other common drugs being used are gabapentin and pregabalin, 5-HT1A receptor partial agonists like buspirone, monoamine oxidase inhibitors, hydroxyzine, antipsychotics like propranolol and oxycodone. Evidence-based recommendations for monotherapy of anxiety disorders would be the first line treatment for as SSRIs and SNRIs are preferred for generalized anxiety disorder, phobic disorders, and social anxiety disorders. And PCS would be second line for generalized anxiety disorder and phobic disorders. MAOs, MAO inhibitors will be a second line drug for social anxiety disorder. SSRIs are as the first line option and it should be started low and slowly increase in dose. Routine increase of higher dose is not recommended, but a subgroup might benefit. Concomitant by benzodiazepines as initial therapy in the short term may be useful. 8 to 12 weeks of pharmacotherapy at optimal doses may be needed to assess efficacy. Good evidence for the benefit of maintenance treatment, at least up to 6 months. Psychotherapy. Types of psychotherapy would be behavioral therapy, cognitive behavioral therapy, and psychoanalytic psychotherapy. Behavioral therapy include exposure and response prevention, which follows systemic desensitization and inclusive therapy or flooding. Anxiety management techniques like yoga, Zen, and JPMR and biofeedback can be used. And desensitization of the stimulus causing anxiety and eye movement desensitization and reprocessing social skills training can be included in behavioral therapy. JPMR, Jacobson's progressive muscle relaxation technique. It is a progressive muscle relaxation technique, systematic technique for managing stress and achieving a deep state of relaxation. It was given by Edmund Jacobson in 1930s. The underlying principles would be when stressors throw a person's nervous system out of balance, relaxation techniques can bring back into balanced state by providing the relaxation response. The state of deep calmness, that is the polar opposite of the stress response. Cognitive behavioral therapy would use the control of automatic thoughts, the correction of cognitive errors, breaking the association between the events, cognitive arousal, and the maladaptive behavior. Psychoanalytic psychotherapy. It is defined as a set of psychological theories and a therapeutic method which have their origin in the work and theories of Sigmund Freud. The aim of psychoanalysis therapy is to release repressed emotions and experiences, that is, make the unconscious conscious. It is only having a cathartic experience and can the person be helped and cured. Psychoanalytic anxiety is classified into four types, like traumatic anxiety, where ego becomes paralyzed, separation anxiety, separation from loved and valued objects, and castration anxiety, where loss of loved or valued object is seen, and superego anxiety. Depending on the type of anxiety, psychoanalytic methods are adapted and particular treatment is needed. Differences